Welcome back, advanced coders and CDI specialists. Today, we're jumping right into a high-level, audit-focused explainer on some of the absolute most complex inpatient sequencing rules you're ever going to encounter for acute respiratory failure, or ARF. In Part 8 of our series, we're dissecting those strict hierarchies and chapter-specific overrides to see exactly how these critical cases need to be coded.
Okay, here's our roadmap for this explainer. First, coexisting acute conditions. Second, poisoning and adverse effects. Third, ARDS and excludes one rules. Fourth, malignant pleural effusion sequencing. And finally, number 5, the final audit.
All right, let's dive into Section 1, Coexisting Acute Conditions. To kick things off, we really need to anchor ourselves in the official ICD-10-CM guidelines, specifically Section IC10B3, which deals with sequencing ARF right alongside other acute issues.
Imagine a patient is admitted with acute respiratory failure hitting at the exact same time as another major acute condition, like a massive MI, a stroke, or aspiration pneumonia. The principal diagnosis doesn't just automatically default to the respiratory failure. No, it heavily depends on the specific circumstances of that admission. Basically, the problem chiefly responsible for occasioning the encounter has to take the lead.
And this perfectly highlights our baseline Section 2C rule. If both the ARF and that other acute condition are literally equally responsible for putting the patient in the hospital, and assuming there aren't any chapter-specific rules overriding them, you can actually sequence either condition first. They equally meet the definition for principal diagnosis.
But listen up, because here is the auditor's golden rule, and you've got to have this memorized. If the medical record is even slightly ambiguous, or if it's just not crystal clear whether the ARF and the other condition are equally responsible, stop. Do not guess. You absolutely must query the provider for definitive clarification before you drop a single code on that claim.
Moving right along to Section 2, Poisoning and Adverse Effects. Let's pressure test that baseline rule with a clinical vignette and see what happens when chapter-specific guidelines enter the chat.
Think about this one for a second. We've got a 71-year-old guy who presents to the ED in acute respiratory failure. The provider clearly documents that this ARF is directly due to an accidental oxycodone overdose. So what's our principal diagnosis? Does the respiratory failure take the top spot because it's the immediate life-threatening crisis, or does the overdose run the show?
Check out the sequence here. That accidental opioid poisonings code T40.2X1A absolutely has to go first. That forces our acute respiratory failure code, J96.00, down into the secondary position. Even though the respiratory failure is a massive, highly resource-intensive part of the encounter, the rules just totally shift here.
And why is that? Because chapter-specific coding guidelines, like the ones for poisoning, give us mandatory sequencing directions that take absolute precedence. In this case, the ARF acts purely as a manifestation of the poisoning. It's a great reminder that chapter-specific overrides will trump your general respiratory guidelines every single time, no exceptions.
Okay, Section 3, ARDS and excludes one rules. Let's turn up the clinical severity a bit and see how excludes one notes completely flip the script on ARF coding.
Picture this. An elderly female gets admitted to the ICU for acute hypoxemic respiratory failure. They've got her on high-flow nasal cannula, maybe BiPAP, but despite all those aggressive measures, she's crashing. She ultimately requires intubation and mechanical ventilation, and the provider's final statement lists acute respiratory distress syndrome, or ARDS. With a deteriorating clinical picture like this, how do we capture both the ARF and the ARDS on our claim? Well, trick question, you actually don't report both. Thanks to a really strict excludes one note under category J96, when acute hypoxic respiratory failure progresses into full-blown ARDS, you only assign code J80. You cannot code these two together in this kind of progressive scenario. And this isn't just a guess. It's explicitly backed by the AHA coding clinic from the fourth quarter of 2020. The whole logic here is clinical elegance. You report one code to capture the absolute highest level of severity. Basically, the ARDS absorbs the ARF to make sure the claim accurately reflects just how sick this patient really became. Next up, Section 4, Malignant Pleural Effusion Sequencing. Let's tackle what might be our most complex inpatient mystery today, neoplasm sequencing combined with respiratory failure. So this is your classic high-level multi-code stack. Our patient is admitted with ARF and hypoxia. She has a personal history of clitoral cancer, status post-removal and radiation, But during this stay, she's diagnosed with metastatic disease to the right lung and a malignant pleural effusion. After a query, the provider confirms the ARF is directly due to the progression of that effusion, which stems from the historical primary cancer. Seriously, where do we even begin to sequence this?
Let's build the stacks step by step. The secondary lung neoplasm, C78.01, claims the top spot as your principal diagnosis. Boom! Next, you drop the effusion manifestation code, J91.0. Then comes the resulting respiratory failure, J96.01. And finally, you wrap up the whole clinical picture with your historical Z code, Z85.44, for the treated primary cancer.
This very specific 4-code hierarchy is mandated straight from the AHA Coding Clinic, Q3 2025. It is a perfect example of how chapter-specific neoplasm guidelines have the power to entirely hijack the respiratory sequence, pushing ARF all the way down to a tertiary position.
All right, Section 5, the final audit. We have navigated some incredibly dense rules today, so let's quickly solidify these takeaways so your documentation is bulletproof. Let's summarize the hierarchy. Baseline: equal selection applies unless overridden. Override 1: poisoning guidelines will always beat out general respiratory rules. Override 2: ARDS literally absorbs ARF via and excludes one note to capture peak severity. Override 3: metastatic neoplasms dictate the sequence over any resulting effusion or ARF. And the ultimate rule across the board: if it's ambiguous, query the provider. Don't risk it.
Believe it or not, we are just scratching the surface of complex respiratory coding. In Part 9 of this explainer series, we're going to unpack the procedural headaches of ventilator-associated pneumonia, or VAP, and look at exactly how to sequence organism-specific codes with influenza. Until then, I want you to ask yourself a hard question. If an auditor pulled your last 5 ARF charts right now, would your sequencing survive the scrutiny? Keep your clinical documentation sharp, always double-check those overriding guidelines, and decode healthcare with Harshal.